Hi there, everyone. We are so happy to have you, whether you are joining us here today or will be watching later from our Cure GABA-A YouTube channel. We ask that you please mute your mics if you have not done so already, and include any questions that you might have in the chat box below. We will have time to answer questions at the end of the presentation. My name is Monica Joanna Alnacave, and I'm the founder and CEO of Cure GABA-A, a nonprofit organization with the sole focus to develop potential therapies for GABA-A variants. By partnering with world-renowned researchers in GABA-A and the Organization of Patients for Clinical Trials. Today we welcome Dr. Sebastian Ortiz, who is one of our recommended physicians and works very closely with Dr. Reggie Moeller and Dr. Katrine Johannesson in Denmark. He is listed on our website as a physician we refer all of our Cure GABA-A patients to, as he is working closely to develop biomarkers through EEGs and movement data. Dr. Sebastian Ortiz is actively engaged in international epilepsy communities, serving as the chair of the Young Epilepsy Section from the International League Against Epilepsy. His contributions to various international congresses, including the International Epilepsy Congress and Latin American Epilepsy Congress, reflect his dedication to advancing knowledge in his field. Dr. Ortiz is multilingual, fluent in Portuguese, Spanish, and English. I'm handing it off to you, Dr. Sebastian Ortiz. As one of our recommended physicians, our community is so excited to meet you.
Thank you, Monica, and thank you for the invitation. It's my pleasure to be here with you today and to share what we have been doing in Denmark in terms of research. So today we will talk about the clinical phenotype and the functional characterizations that we have done in patients who have GABA-A receptor variants. So first of all, I would like to thank you for all the effort and all the work you have put into finding the patients and gathering all together. And let's us remember that we are not talking about a gene. We are not talking about a position or a variant or an epilepsy patient. We're talking about these beautiful smiles that we have here. So let us remember that all the things that we are doing are for these kids to be able to keep smiling and for the families that they are taking care of. So I don't have any conflicts of interest for this presentation. This is the overview. So we will start with an overview about what are we talking about when we receive the genetic report. Then we will talk very briefly about what is a GABA-A receptor overview. And then I'll deep into the phenotypical spectrum that we have found in our cohort. Afterwards, we will have some conclusions, and I would like to invite you to the studies we are conducting in our center here in Denmark. So once we receive the patient's report, you need to have into account that we have some genetic information that we evaluate through blood sample or saliva or whatever sample it is that translate what is in the DNA into mRNA, and then the mRNA is translated to a protein. So for us to have a protein, we have to have amino acids that are usually built of 3 pairs of RNA and DNA, pair of bases. So if we have a variant that stops the reading of the frame, that means the protein is cut off at some point and therefore it's not complete. That's what we call a truncating variant. So this is usually the case when you have this stop signal that says to the body, do not keep reading because this is the end of the protein. Of course, this is a variant that leads to a degradation of the protein because it's not complete. So we have a different type of variants. Instead of not reading the entire protein, we can have deletions. That means that we are missing 1 pair of base. That means that we are switching the frame 1 amino acid ahead. We can have insertions that also modify by adding another amino acid, or we can have inversions. That means that we substitute 1 amino acid to another one. So in this case, we have what we call a missense mutation. That means that it changed the sense of the reading that would lead to a protein variant that ultimately will probably leads to a disease. So in the case of GABA, we have a dominant effect. That means that we only need one mutation to have in one allele to have the disease, whereas in other diseases we need to have both alleles, and that's why we found other diseases called heterozygous or autosomic recessive disorders. So when it comes to the GABA, we often see these kind of pictures in the articles and the books we read in medical school. And it's basically saying that we have 5 subunits that are binding together to build a pore, where the chloride is transported from the extracellular domain to the intracellular domain. So let us remember that the chloride has a negative electricity, so when it enters the cell, makes the cell more negative. That means that the cell, it's most likely not to be activated when received another input from other channels. So this is the usual heteropentamer. That's what it calls. It's built usually from 2 alpha subunits, 2 beta subunits, and 1 gamma subunit. But we can have a lot of alphas, a lot of betas, gammas, delta, epsilons, or theta variants. The other way we can find this kind of reports and papers is these letters. These letters are the amino acids. So it's like the code we have to build one subunit, let's say in this case the A, the alpha one. And here, for example, the red dots are pointing out to the mutations that we have found in patients who have this kind of disease. Of course, we can have variants that do not cause disease, and then that's why we often are very cautious in reviewing all the variants, saying whether this is a pathogenic variant that means that causes the disease, or a benign variant that says that it doesn't cause the disease. So when you go and look at the protein within the body, it doesn't look like this. It looks more or less like this. If you put a line here, then you will find the extracellular domain up here, and then the intracellular domain in this region. And we have found that in some locations, you can find a different phenotype outside, whereas inside you can have another phenotype. So just to remember that when we are talking about alpha, gamma, delta, or beta subunits, we are talking about one subunit in the whole. So we have 2 types of actions that the GABA receptors perform. One, it's the phasic, and the other one is the tonic inhibition. Usually the phasic inhibition is intrasynaptic or presynaptic, and the extrasynaptic, that means it's outside the synapse of the neuron, it's called tonic inhibition. And also, we need to take into account that the GABA it's built from other substrates. So sometimes we can have different inverse errors of metabolism that can cause also GABA phenotypes. So once we have seen the genetic report, we come to the lab with the help of our colleagues in Sydney, and we try to test the variant. So how do we do that? So this is a very nice example. It was published a couple of years ago, where we construct a concatenated receptor. That means that we are building a DNA with all the receptors, the subunits that we need to build the receptor. And in this case, we have a variant in the beta-3 subunit that it's pointed out here with the star. And in the model, we expose these channels to different concentrations of GABAergic drugs, or GABA, to see whether the channel opens normally. This will be the black line that we call wild type, or if it's open more rapidly, there will be a gain of function, pointed out in blue. Or if it's a loss of function, that means it needs a lot of concentration just to open. So we are coming from the genetic report to testing the variant, then that will take a couple months at least. Of course, what we have been doing in the past years is to find out all patients with all variants, and we have been testing alpha 1, beta 2, beta 3, and gamma 2 variants, also delta ones. So that's the lab thing. But what about the clinical spectrum? Because, of course, as we started with this first slide, this is not about a channel, this is not about a variant, it's about people, patients, daughters, sons, siblings that have this disease. So it's in a spectrum. So we can have from very mild things to a very severe end of the spectrum. So in this slide, I will focus mainly on the cognitive aspects and the epilepsy aspects of it. So we can have people with normal cognitive or very mild cognitive disabilities that can go to almost mainstream school. Probably those are the patients where we are lacking the most information of, because we do not test these patients because they are normal cognitively, because usually the epilepsy is also mild. Uh, as you move towards a cognitive decline, whether it's moderate, mild, or very severe, then we start thinking as physicians to get tested, because most of our patients have negative MRIs and negative background past medical history. So we do know that if you don't have any risk factors and then the MRI is normal, then you should proceed to genetic testing. So what about epilepsy? I will start from the most severe ones and move to the most milder ones, because the most severe ones that are with the new epilepsy classification uh, are the ones that we test more rapidly, because they are very critical, they are very young, and they have a lot of seizures, like at least one third of our patients. Uh, and we have found that we can provide treatment implications that we will discuss a little bit further. When we are talking about the intermediate spectrum, we can find that most of our patients with febrile seizure are suspected to have Dravet syndrome at the very beginning. But we do know that patients with GABA variants do not have Dravet, because Dravet has different trajectories, treatment implications, and the trajectory as our patients are getting older is quite different from the Dravet. Also, we can find the developmental epileptic encephalopathy patient. That means that we cannot classify them in a very specific epilepsy syndrome with a very specific seizure type, but we know that they have a very cognitive impairment, a very severe or moderate cognitive impairment with sometimes refractory epilepsy. And then we can move to the milder group that have just febrile seizures, uh, genetic epilepsy with febrile seizure plus, and then some genetic generalized epilepsy. And these, again, is the group that we are testing the less, because they are usually seizure-free and with normal cognitive profiles. So we need to be aware that probably we have a bias in selection, because the patients that we have had study are the most severe ones in this end of this line. So we have addressed this previously by Katrina Johansson in this neurology paper published in 2016, where we can find the formerly benign phenotypes, now we call them self-limited phenotypes, and the very severe phenotypes. As you can see, it's almost one third that can be severe, mildly, and then benign. But this spectrum is not about, it's not only about epilepsy, and we need to be aware of that, because sometimes we just focus on the seizures and we often neglect research and then treatment to other things that are very important. Let's say about neuropsychiatric symptoms, we can find patients without epilepsy with autism spectrum disorder, patients with ADHD in this mild spectrum of the neuropsychiatric symptoms. Whereas as we move towards the right of the slide, we can see severe autism spectrum disorder. We have had at least one or two reports about catatonia related to GABA, and then schizophrenia has been related also to GABAergic variants. So we do know that the neuropsychiatric features are really important, and probably the most overlooked symptoms that we have in these patients, because of course most of them we are worried about seizures and then the likelihood of having difficult to treat epilepsies. One thing that we are deeply studying and deeply involved in the international consortium, it's about movement disorders. We have found that almost 1/5 of our patients, especially the most severe ones, when it comes to severe autism spectrum disorder, severe cognitive impairment, or severe epilepsies, can have movement disorders. It can have ataxia. It can be debatable where ataxia is or not a movement disorder, but tremor, dyskinesia, and then the most severe ones are these three. We received last week a patient with a childhood Parkinsonism of the newborn. So Parkinsonism can happen in the newborns, and probably because this kid was seizing, nobody was actually that worried about the Parkinsonism of this patient. But also dystonia, where we have developed some collaborations and skills to assess the dystonia and also the chorea of the patients that we are studying. So what about the EEG spectrum? Again, this can be also tricky because patients can evolve during time when it comes to the EEG. You can have sometimes normal EEG, you can have very abnormal EEG, but then what is important is the time where you take the EEG. If you have a patient with spasms and then you have hypsarrhythmia, then that means that you have an epilepsy with spasm syndrome. And then you need to treat the patient as we have a robust body of evidence. And we do know that the prognosis is not that good. So we are classifying the patients based on the EEG as well. And we have gathered some EEGs, but we're working on gathering more so we can find some biomarkers in the EEG that can provide the clinicians tools to find out whether with the report or without the report and to think about these diseases. This is just an overview of the about 990 patients that we have in our database. Just one subunit, we have about 111 gain of function, 165 loss of function, a very variable onset. You can see 1 day to almost 2 years. It's equal in terms of females and males, and then almost all patients have epilepsy. Another thing that we have found is that, for example, in the most severe end, we can have microcephaly, but microcephaly is not primary microcephaly. That means that you are not born with a small head size. It develops over the time, very like resembling the Rett syndrome. In these girls, they have normal head size, and over the time, the head stops growing, so they end up with microcephaly. Also, age of onset, the earlier you start, probably the most likelihood you have a very severe phenotype and a very poor outcome when it comes to cognitive. Whereas you have a febrile seizure, probably you are in the mild to moderate end of the spectrum when it comes to epilepsy and also a cognitive outcome. This is a paper we published, the group published about a couple of years ago in beta 3, where we compare gain of function or loss of function, because we're aiming not only to test the variant, but also to provide some tools to the clinicians to find out with the clinical symptoms whether you have a loss of function, a likely loss of function, or a likely gain of function. In this slide, you can see that we can compare the age of onset. It's very statistically significant and very early compared to the loss of function. Also, febrile seizures and seizure freedom are more likely to be in the loss of function, whereas severe intellectual disability, focal seizures at onset, hypotonia, and microcephaly, these four are related to the gain of function. So we have very strong predictors, and we are developing a tool for clinicians to be able to identify whether it's a gain or loss based on probability and clinical symptoms. But in the end, what are the implications about this phenotyping? And then will it help my kid if you have a gain of function or a loss of function? The answer will be probably yes. We are not there yet to develop specific compounds to the gain of function or the loss of function, but we do know that in some variants, especially the gain of function, when you treat them with GABAergic drugs, they can have seizure responding phenotype, but then very severe adverse effects, such as somnolence, drooling, breathing difficulties. So we need to be very careful in this end of patients, in the end of the spectrum, that it's very severe gain of function when we are using GABAergic drugs, because sometimes, especially in patients that have certain specific variants and specific phenotypes, you can worsen the clinical scenario, and then it can lead up to be a very critical baby in the ICU or the NICU. So we do know that this has clinical implications. But what about loss of function? We have recently published a paper about the effect in one patient with alpha-1 about vinpocetine. And we do know that it's not for all cases, but we are going to study this in very deep. And then we have recruited some patients here in Denmark, and we will publish the results probably the upcoming year. So now we need to define the clinical trajectories, because of course now we know what's the functional outcome of the variant. We do know where to put our patients in this scheme of severity or non-severity. But then the second most asked question is, what would happen with my kid? Is this going to be lethal? Is he going to be, or she's going to be handicapped? Is he going to walk? Is he going to talk? So we're trying to aim this and tackle this by building a natural history study. Of course, this takes time, this takes effort, and a large amount of resources to define these clinical trajectories, but we're one step closer. I know this is a messy slide, and the upcoming 4 slides are just like this, but it's not for you to see the trajectories, just to see that sometimes we have patients with genetic generalized epilepsy, such as juvenile myoclonic epilepsy, where we expect to have very good seizure outcomes. But in this case, 1/3 of the patients have partially good response. One third of the patients, they are seizure ongoing, and then 1/3 they are seizure free. Same thing, for example, with the Dravet syndrome. Some of them have poor response, some of them are seizure free, and some of them still having some seizures. And what about if we compare epilepsy syndromes with cognitive outcomes? Again, same busy slide. You can see from severe end, you can find focal epilepsies, epilepsy with very early onset, epilepsy with Dravet syndrome, epilepsy with infantile spasm syndrome, and then also unclassified epilepsy. So we do know that one symptom does not predict the outcome, and that's why we're building this matrix to find out what are the commonalities and the pathways that the patients are going through in their lives. So just to show you what we have found in some of our patients in one of the cohort we are studying, we are finding the patients in a specific domain within the protein. As I mentioned in the very early slides, we can divide this in the extracellular domain and in the transmembrane domain. And then we are grouping in the age of onset of seizures, then whether they have or not seizures, the epilepsy syndromes, the type of seizures, and then the seizure outcome, and then the cognitive profile. As you can see, each patient is an individual trajectory, but we will come for each and one of your patients, and we will try to find which trajectory they are going through. So as conclusions, we do know that functional testing is not always available. We do know that sometimes as parents, we have the urge and the need of having this functional testing right away, but it takes time, it takes a lot of resources and a lot of efforts, but we're doing our best to provide the testing. But then we can find the variability in the clinical presentation, and then based on the clinical presentation, we can predict probably with a very high likelihood the functional characterization. And then we will work together with Cure GABA-A to find the unmet needs, because of course, one thing is what I think it's needed, and then probably another thing is what you as families and patients wants to know. So this is my one of the last slides. These are our research projects. As you can see, we're working on the movement disorder assessment. So some of your families have received video guidelines on how to record the videos for us to assess whether the patient have dystonia, dyskinesia, chorea, tremor, and walking assessment to apply some ataxia scales. We have just launched the treatment response survey because we need parents to fill these data, because we need to know the length of the treatment, the most efficacious treatment to provide you with answers. We will work on the natural history study and the EEG biomarkers. But for this, we will have to have your consent. So we will circulate the consent for this. And if you scan this QR code, but I will go into do it bigger, you can scan this QR code and then access the survey about anti-seizure medication. So I would like to thank you, Monica, and all the Cure GABA personnel who has been working tirelessly and fiercely to find researcher and answers to the patients. And I would like to thank all my colleagues here in Philadelphia that are working together to find the answers. Thank you.
Thank you so much, Dr. Sebastian Ortiz. That was such a wonderful presentation, and we are so looking forward to all the wonderful things that we are going to come up with for the Cure GABA-A community. We're grateful for all the work that you put in.
Oh, thank you.
The QR code that you presented, would that take them to a survey that is also on a platform called Matrix, or is this an independent survey within your clinic?
It's an independent server. Takes you to a link here in Denmark.
Okay, wonderful. So you know what we'll do? We will maybe by tomorrow or the next day, I'll add it to our website. So it'll be one of the steps that our patient caregivers can do. And that way it'll all be in one place.
Yeah, perfect. That will be awesome.
And if there's any other information that you would like us to include on the website, just please email me.
Yeah, sure. And then that was my email as well. If you want to contact me, then I'll be more than happy to talk to you and the families that have patients with GABA variants.
You know, every single person that we come in contact with, we always refer them to yourself and Reiki. Because collecting the EEGs is such an important study, and so is that movement study. I think once we have the data, once you've compiled the data and you can share it with us, it's a game changer.
Yeah, definitely. It will improve our patient's life, probably.
Absolutely. And that's the goal here. So I'm so grateful to have met you. And thank you for making this presentation today. We'll talk soon.
Yeah, okay.
Bye.
Bye.
Bye, everyone.